Good evening, everyone. Today, for this fourth module of the IFS SIG Research Methodology webinar, we bring to you two papers that will be read out to you by students, IFS students, and will assist you in analyzing those papers and to help you in deciding whether you take information back from these papers at all or not. So this critical thinking is essential in the day of AI today. I mean, you get answers easily. If you type that question on your phone, you'd get a very, very quick answer. However, AI is not able to do what is known as a critical analysis. It will pick up what is there, what is available, and put it out there. It is an information-based system. It is able to do this quicker, but the role of what this paper is about, how much to believe in it, what are its flaws, what are its positives, is still remains the job of the reader. Okay, and which is what this webinar aims to do. Today for this webinar, we have the Secretary General with us of IFS, Dr. Shweta Mittal, who would be talking to us briefly. May I now invite Dr. Shweta to address the gathering.
Good evening, everyone. Thank you, Dr. Ruma. I think this topic, what you have chosen, is very important, not only from the point of view of students, beginners, but also, every time, even for us as consultants, when we are made reviewers of journals and we get these articles, it's very important to have the critical analysis to know, if the study design or the question was correct and how was the analysis done and how to critically analyze to accept the paper, not to should it be coming in the journal in itself or not. And if it has come out, it needs to, because every article will change our practices. We believe that article, we start following certain things, when we read something new. So it's very, very important that we should be able to judge it. So it was an excellent topic chosen. And before I hand over to Dr. Ruma, I'm inviting everyone to our Fertivision, which will be held on 12th, 13th, and 14th of December in Delhi this time. And this is what I had thought, manuscript writing for the research and methodology SIG. So all the keen viewers of this SIG today can participate and present your work. Thank you, Ruma, and handing over back to you.
Thank you, Dr. Shweta. That's very encouraging. Thank you. May I now invite Dr. Aarti Mishra she's an IFS student at Bhopal, Her Health, and she would be presenting this paper. It's a retrospective study on PGTA implementation in single embryo transfer cycles and whether it leads to an improvement in cumulative live births. Dr. Aarti Mishra.
Good evening, teachers. My screen.
Are you able to share your screen?
No, ma'am.
Have you pressed the share screen icon?
Yes, ma'am. It's either because of the network or...
No, we can ask him to make you co-host or something.
I think he's already done that, but I'm not able to share the screen, ma'am.
Want to exit and enter again?
Okay. I think.
Himanshu, if you're there, please help Dr. Aarti.
It's saying please grant browser access to screen recording and then it's stopping. अगर आप कुछ बता सकें.
Are your slides with one of us?
Yeah, I think I can share it.
Try sharing those slides, Garima.
But I give me a minute. I need to download it.
Yeah.
I am. Can you tell us something about the article till then, Aarti? What is it about? You can start about that.
Yes, ma'am. The article is about the success rate pre-implantation genetic testing for it's a good process patients dependent on age. Retrospective study done along a period of 2016 to 2019 on a study population of 56,496 um, single retrieve cycle patients. PGTA during in vitro fertilization or IVF is used to evaluate embryos for aneuploidy and identify chromosomally balanced or euploid embryos for transfer. Aneuploidy is the most common reason for miscarriage, representing about 50 to 70% of it. The risk of oocyte aneuploid increases with age, and there's no escaping that, with increasing likelihood of aneuploidy increasing over 35 years. There are various methods for testing. We'll be talking about PGTA, which PGTA in this case is done with next generation sequencing. And this supposed to be the most accurate for it, with a sensical error rate of only 0.7%, is to evaluate the cumulative life with NGS compared to morphology that we usually take alone amongst patients between 21 to 40 years undergoing single embryo, single blastocyst transfer. The secondary objective includes clinical pregnancy rate, live birth rate, and miscarriage. This study is a retrospective study to identify first autologous retrieval patients between 21 to 40 years undergoing single blastocyst transfer with or without PGTA using NGS from 2016 to 2019. And a modified Poisson regression modeling was used to evaluate the association between PGTA and the cumulative live birth rate. The exclusion criteria for this study are cycles with patient more than 40 years, total number of fertilized oocytes if less than 5, thawed oocytes, embryos used from bank, gestational carriers, cleavage states, mixed embryos from multiple stimulation cycles, recurrent pregnancy losses, and any fresh transfers, and any other form of pre-genetic testing like M or SR or HLA. Statistical analysis. While analyzing this, the patients were categorized into 3 cycles: less than 35 years, 35 to 37 years, and 37 to 40 years. Patients and retrieval cycle characteristics were described as mean standard for there are two variables that are taken: continuous variables or as frequency or categorical variables. PGTA group between 35 to 37 years and 35 to 37 years, the difference was 62.5% versus 59.1%, and 59.3% versus 44.8% between 35 to 37 and 38 to 40 years. A modified Poisson regression model was used to evaluate the overall association between PGTA and cumulative live birth rate. For adjusting the covariaties between per retrieval cycle, the covariaties were race, ethnicity, BMI, nulliparity, smoking status, infertility, and number of blastocyst transfer. Results. I will show you the result here. Individuals Ma'am, I also forgot to mention that
Aarti,
SART
just give it a second. We'll just check with Dr. Garima if she's been able to download the slides. And if she hasn't, then it's best to understand how to open your presentation on this.
yeah, because the result.
Ruma, just give me a minute. I think it's downloading now. I had
Also,
trouble.
you can talk
Yeah,
to,
I'll just share it with you. Yeah.
otherwise, I've given your number, Aarti, to Himanshu. He might call you up because there's something you have to change in your setting.
Okay, so I'm sharing the slide. Let's see if we can get this.
Yeah.
Setting.
Now, can you see the slide?
Yes, ma'am.
Yes, we can, ma'am.
Okay. So, Aarti, you can just quickly recapitulate what you have said for the benefit of the audience.
Ma'am, just
The
do it in the screen share, please.
Sorry,
Screen share.
ma'am, screen share.
I'm
Sorry,
sharing the
sorry, in
screen.
the PPT mode. Slide view. How do I see
Ah,
it?
I'll do that. Yeah, that I'll do. Just a second. Okay. Yeah.
The topic for today's discussion, like I said, was success rate with PGTA in good prognosis with age taken as the parameter. PGTA
I think
during
yeah.
IVF is used to evaluate embryos for aneuploidy, identify euploid embryos. It's the most common cause of miscarriage, carrying about 50 to 70% of oocyte aneuploidy increases with maternal age and increasing likelihood having a factor more than 35 years. This is a retro 2019 on a study population of 56,496 single retrieved cycles. The primary objective is to evaluate the live birth rate with PGTA done by using next generation sequencing compared to morphology alone amongst patients from 21 to 40 years. And the secondary objective included clinical pregnancy rate, miscarriage rate, and live birth per transfer. This is a material and method used were a retrospective cohort study to identify first. I added. This is actually done using the cohort analysis is done using SART analysis to identify first autologous cycle in patients between 21 to 40 years undergoing single blastocyst transfer with or without PGTA using NGS from 2016 to 2019. Modified Poisson regression module was used to evaluate the association between PGTA and cumulative live birth rate per retrieval. What? Exclusion criteria, age, patients more than 40 years, recurrent pregnancy losses, cleavage transfers, any fresh transfers, total number of oocytes retrieved less than 5, any other form of pre-genetic testing like SR or M, thawed oocytes or embryo banking, cleavage state transfers. Statistical analysis while uh, at the time of retrieval they were divided into three categories: less than 35 years, 35 to 37 years, 38 to 40 years. Patient and retrieval cycles were described as mean for two variables: continuous variables and categorical variables. PGTA group, uh, 62.5% versus 59.1% in age between 35 to 37 and 51.3% and 44.8% in both the variables in age between 38 to 40. We've taken these two major because these have majorly shown findings. Less than 35 years didn't really, PGTA didn't really matter. A modified Poisson regression module, like I said, was used to evaluate the overall association between PGTA and cumulative live birth rate, adjusting the covariates. The covariates, so to say, were race, ethnicity, body mass index, nulliparity, smoking status, infertility, and number of blastocysts. The results. individuals who used PGTA were 3% more likely to have a cumulative live birth rate than individuals who did not use it. But this began only after more than 35 years. When stratified by age, individuals less than 35 years at retrieval who use PGT testing were 4% less likely to have cumulative live birth rate than individuals who did not. Um, those using PGTA were more likely to have cumulative live birth rate than individuals who did not use it between 35 to 37 years, and individuals more than so overall individuals more than 35 years using PGTA, there were higher proportions of clinical pregnancy rate, live birth rate compared to individuals who did not use it. This is a table showing the same thing. In less than 35 years, there is no difference between the risk ratio. But in individuals between 35 to 37 and more 38 to 40 years, there's a significant difference between usage and not usage in terms of clinical pregnancy rate, miscarriage, live birth rate, and a cumulative uh, live birth. But the limitation of this study is there is a 1.2 to 5% risk of no read result, which may preclude some euploid embryos from being identified as appropriate for transfer. Uh, uh, and the use of PGTA may also lead to embryo damage or embryo loss or unsuccessful biopsy or failure to amplify the DNA. So this has a major role in individuals less than 35 years. So they are, rather than being benefited by this, it's a loss for them. So in conclusion, PGTA was associated with a higher cumulative live birth rate among individuals more than 35 years, and there was no difference in individuals less than 35 years. Miscarriage was significantly less likely in PGTA cycles compared with no PGTA in individuals more than 35 years, and there was no difference in individuals less than 35 years. Thank you.
Thank you, Dr. Aarti. It was a very good presentation and indeed a very good study.
Thank you.
This study was published in Fertility Sterility. And keeping this in mind, Dr. Aarti, I have a question for you. What do you think was the research question for this study? What were the researchers questioning, or what was the principal research question for this study? Are you there with us, Aarti?
Ma'am, yes, ma'am. Yes, ma'am.
Yeah.
Two, one, if PGTA, because nowadays in the studies, especially in this study also, it was shown that a lot in US, more than 60% people have been using PGT and going for it. So does it actually help? And we actually need to, because it becomes very easy to do that, but it also has its limitations. So is it actually needed in every cycle for every individual, irrespective of the age, and is it actually as helpful? I think that was the primary goal while formulating this study.
Okay. I think, Aarti, what you have beautifully brought out is the question that what the investigator had in mind before he was starting the study. That what is the role of PGTA in current practice of IVF, and who are the patients who can benefit, if any can benefit? Because we know there's always a risk of losing some good quality embryos in the process. So this was the main question that has happened. But when you're formulating a research question, it has to be very scientifically termed, very objectively termed, in a simple layman language. Okay. So this is the first, what you have highlighted is the need, basically the query that must have come in the mind of the investigator. But in order to have a scientific study, the first step is from going from this query to actually formulating a proper research question, because this research question is going to further formulate it's going to form the backbone of your study, because it's going to formulate your hypothesis and the what is the kind of study you will do. So keeping this in mind, what are the principles when you're designing a research question is that it has to be said in a simple layman language. Obviously, it has to be a question. This has to be peer review. Just like you said that I want to know whether PGT is good for my patients, but that is not it is. You have to specify what are the subjects that you're going to subject to, what is the effect. So basically, it is a question that tells you what you want to know, not what you will do. So for keeping the objective in mind, I want you to read the objective and then we will go to what is the research question. Can you read the primary objective of the study?
To evaluate cumulative live birth after PGT-A with NGS compared to morphology alone amongst patients between 21 to 40 years undergoing a single blastocyst transfer.
So basically, he questioned whether PGT is essential or not, and probably this researcher has gone back and has discussed with his peers, and they have realized that yes, the studies that have shown that PGT is not good were using earlier technique. Now with NGS, we have a better chance, and with more experience. So now he has framed this question in such a way that the research question could this be to determine if cumulative live birth after pre-implantation after PGT-A with next generation sequencing uh, compared with morphology alone, you give a hypothesis is better than is it better than doing just with morphology among patients aged
Morphology.
21 to 40 years with single blastocyst transfer. So now he has actually specified that I want to do PGTA only with NGS. My patients have to be between 21 to 40 years who are undergoing that. And yes, you can add in good prognosis patient because as you have said that he's excluded patients with less than 5 blastocysts, and he's specifying that he's talking about single blastocyst transfer in the further hypothesis. So I will just show you. I think I'll just show you what I have framed for this. 1 second, just give me a minute. I will I will just show you that. Okay, so yeah, so that is the objective. So when you're framing a primary research question, you must remember that it has to be properly framed. It needs to be given a thought over because here he decided to do NGS. What is the end level? What is the transfer? What is the number of embryos? What stage transfer he's talking about? His primary goal is cumulative live birth. He basically wants to know what is the chance of giving a baby whom. Okay, versus you doing a clinical pregnancy. So everything needs to be worded out. Simple language. It has to be relevant. It could be implementable. It has to be a practical solution that you're doing it. That is how your research question to be framed. And that is the first step that you do when you are actually taking out a study. Okay. Now, my next question to you would be, what is the type of study here that we are talking about? What is the study we are talking about here? What was the study design?
Retrospective study.
Would you be able to tell me what do you understand by a retrospective cohort?
Ma'am, that
You
we
Yeah,
are
you
not
can tell me.
doing it in the present time. I mean, the patients are not in the
Yeah, you can tell me
present.
what do you understand by a retrospective cohort? When do you say that a study is a cohort? As as you can see in this, basically cohort is a group of subjects with similar characteristics. Okay, so when we say a cohort study, it's a longitudinal study where you are following the patients from the time when they're apparently clinically healthy to whatever exposure you're subjecting. In our case, it is we are subjecting them to IVF with or without PGTA. And then you see that our outcome is after your IVF, whether it is she's conceiving, she's having a baby, take home baby, or she's not having a take home baby. So basically, cohort is when you start from initial subject, you're subjecting them to an intervention, and then you're looking at the outcome. Okay, that is a cohort. Normally, a cohort, as we all understand, is a prospective cohort. Here we are talking about retrospective cohort. What is it? That you are following the subjects before the exposure, before you're recruiting your subjects, before they are undergoing IVF, and you're looking for the outcome depending on whether, according to the PGT done or not PGT done, right? So this you're looking from back. Here your investigator is basically looking at behind. So basically this is when we say the concept of retrospective cohort. So here they have undergone, all your patients have are undergoing IVF. Normally you would go to a prospective. Here we are going you're taking out the old records. Now this could be done through old records and all. Like in this case, you have this huge SAR data. You have huge, enormous 50,000 data that you got. This could be done through retrospective cohort. So this being a retrospective study, Aarti, what is your take on it? Why do you think the author investigator chose to do a retrospective study? Was there any other way in which he could have conducted the study? Any other way? Yeah,
Prospective study.
yeah. So prospectively, if he was doing, he could have done a prospective. cohort, right?
Hmm.
Any other way do you think that your investigator could have done a study? We could have got a better quality evidence?
Uh, hmm.
What about randomized clinical trials? Do you think they could have done a randomized clinical trial?
Ma'am,
Yeah, that could have been done. Okay. Yeah, that is it. So basically, just to see, basically, how do you start? I think we all are puzzled when it comes to what is the kind of study. So you actually need to understand first what is your study. Is your study putting an intervention or is just an observational study? So our study is obviously RT, it's an interventional study.
Interventional study.
We are doing an interventional study, and but again, this intervention is not done. These are things that are already done. We are just comparing the two groups. You're not actually introducing an intervention. So this will fall under the category of
Observational.
analytical study.
So,
We are doing a comparison, but we are not introducing an intervention by experiment. This is something that is happening. We are just analyzing the difference in the two groups. So when you're doing an analytical study, it's an observational study, and where you're comparing two groups, then you can do it various ways depending on cohort, case control, and cross section. Okay? Only when we are introducing an intervention, yes, randomized control trial would be a. Though we all know randomized control trial is the pinnacle of evidence and it is supposed to be a very good quality, but again, what is the problem with RCTs or RT?
that
Yeah,
I know that
it's
it's
a very good quality evidence, right? We all understand that. But then what is the problem? Why did the author not do an RCT? And he's done a retrospective cohort and it's published in such a good journal. Why? Why do you think?
it
RCT,
require.
sorry. RCTs are a very labor intensive thing. There's a lot of funds involved and it's a lot of labor intensive. You have to look at a lot of things about there are a lot of protocols that need to be adhered to. And we had such a large number here, around 50,000 patients, right? So this amount of patients doing in an RCT may not have been financially possible. So hence, when you are doing a study, we decide what is the intervention. So ours was an analytical study, and we know it's a IVF is a very common thing, and NGS is you are doing it. So you basically decide what you want to do with your study, analytical study, and you can easily cohort is a good way to follow. Okay, but when we do a prospective cohort, the problem with a prospective cohort is like any prospective study that you do. What is the problem with a prospective study? As
Follow
there is
up.
you need to follow up your patients. So your patients have to be followed. So though it's good, you can have multiple outcomes, but it's expensive, it's time consuming. RCT more so even prospective cohort, and you have always a loss to follow up. Hence, to overcome this, many people you can in many situations like this you can do a retrospective cohort where it's you're just taking out the data, so it becomes easier. Time gets less. You can even look for unusual exposure, longer follow-ups. You're following up patients till you have a long period of follow-up. You said in 2016 to 19, so you have easily a period of 3 years follow-up. Imagine doing it with a prospective study. What is the amount of infrastructure and investment that will require? And you can even study long incubation period. All right. So, but again, these studies are not perfect. There are certain flaws, like the potential for bias. Obviously, because we don't know the selection criteria, obviously it has not been followed any. It's obviously from day-to-day practice. Recall bias or information bias, as you have probably there in the article, which may be pointed out later, that some amount of information is missing, which is just presumed. Then you don't know about the data control. What was the quality of data? How it was recorded? We don't know. We are just going by the records, and obviously sometimes you have missing records and incomplete, and then definitely there's confounding variables. So I think in the end, all said and done, though RCTs are the pinnacle of our research, and this is the best way to do it, but it may not always be possible to do. And in certain situations with such large amount of data, these kind of studies also help us getting answers we want. Thank you.
Thank you, ma'am.
Thank you, Dr. Garima. You very nicely and elaborately discussed on the research question and study design.
Yeah.
So now to discuss about the statistical concepts in the paper, I would like to invite Dr. Roma Satwik. She's a senior consultant and professor at Center of IVF Human Reproduction at Sir Gangaram Hospital, Delhi.
Thank you. See, whenever we read a paper and whenever we read it from these journals like fertility, sterility, and human reproduction, and we have this habit of quickly jumping to the conclusion because it saves us time. We assume that these journals, just because it's prestigious, it has done its due diligence in selecting that article, there has been through the review process, and it's come out there. And which is true that, I mean, publishing SART data from 56,000 cycles is, I mean, does deserve attention. I'm not going to deny that. What, and it's not even a rare thing. A place like the US, as per the study that Aarti showed, Aarti, are the figures 58% PGT cycles for women between 38 to 40? From what I remember, it's 58% for that age group, about 20% of women between 35 and 36.
35 to 37 years.
Yeah,
Yeah.
yeah.
Hmm.
And about 20% of women undergo PGTA cycles between 35 and 37. And as per this study, they had about 4% in the less than 35% group. So that would add up to a significant number and cost, and one definitely needs answers. Not that there aren't answers. There have been trials, there have been different kinds of studies, there have been large data studies that have been coming in and out. What is it? Where do you put the lens on these studies? I mean, if I were to quickly go to the conclusion, I will just start there and then move on to, because your antenna should be raised, and that's the bottom line. But I'll start with the bottom line and then go back. Your antenna should be raised anytime you have a positive influence coming out of a study. Okay. Remember that the default is null, that there is no difference. Okay, that's where you start. If a study, and if a large data study, of course, that is catching my attention, is saying that this is making a difference, it is making a difference in certain age groups, my antenna are raised. I'm going to now go back and see what is it, how has this study been done, retrospective and all understood, great. But I'll look at everything else to see, really fine tooth comb it to see if this really stands the scrutiny of what would be called the scientific method, right? Can we have, okay, I can display my slide. I just have 3 or 4 slides to show. There aren't too many. So just going to, I'll quickly look now. Once I have been told that this is making a difference in a certain age group above 35, I want to see what population was included. Okay. So you have already said this, Aarti, that these were the inclusions. First cycle autologous 21 to 40 undergoing single blastocyst transfer with or without PGTA using NGS. Those are all the women who undergoing single blastocyst transfer have been picked up. I just want to say one thing here, that women over 38 may have two blastocysts. If they haven't undergone a PGTA, they, as a standard practice, even by the SART guidelines, it's possible to have two blastocysts being put inside, right? And that is also a practice there. So those cycles have been excluded, right? So this is pertaining to single blastocyst transfer, tested or non-tested. Now, I'll also look at exclusions. You already have mentioned most of them, but I'd like to highlight two. One is total number of fertilized oocytes less than 5 were excluded. So clearly the poor prognosis patients are out, as also that the title is very suggestive. It's even answering a question. So it's not even raising that question. It's directly coming to the answer that this is what it is, that it is helping, right? So they already say good prognosis patients. So those are the numbers that have been excluded, and come down to recurrent pregnancy loss. So PGTA is offered to women, or was offered to women up till a certain point, maybe in the duration that the study has been done, 2016 to 19. So those pregnancies or those cases have also been excluded. So whenever I generalize these results, I know that it cannot be generalized to the poor responder. Okay. It cannot be generalized to the women who who have had a history of recurrent pregnancy loss and are in fact going through PGTA for that indication, right? This is what you have already told us, that they have included cycles that had PGTA as an intervention, and the comparator were cycles that did not have PGTA as an intervention. So here is where you look at outcomes, okay? And this also has to be fine-tooth combed. So they do a variety of outcomes. One is cumulative live birth, but the other is also clinical pregnancies and miscarriages with the denominator. So you have to really, really look at what they have put in the numerator, but even more stress on what they have put in the denominator. And why this is especially so for something like PGTA, because cycles that are intended for PGTA might be 100. The ones that end up going through a biopsy might just be 80 or less, depending upon what is the kind of women you have, counseled for PGTA. Of those, the ones that end up with a euploid might be 80% of that. And I'm only giving, very optimistic figures, might be 60. And of these 60, because these are the ones who have euploid embryos. So now if you start with talking about your results per transfer, per euploid transfer versus transfers that have happened without PGTA, there might be a difference. But if you were to understand that per intended cycle, if that was the denominator that you put in, things can look very different. So here, at least I believe their outcomes, and I've only taken one just to simplify matters. I'm looking at cumulative live births. How do they define it? At least one live birth achieved after 1, 2, or up to 3 single blastocyst transfers for each retrieval cycle. This was only included once in the numerator. And this, I think, needs to be relooked at because that's not how they use their statistics. But that is their numerator. And what is their denominator? Cycles using PGTA that did not have embryos available for transfer, most likely because of no euploid embryos, were included in the analysis as having no cumulative live birth. Now, that is something that I appreciate them for, that they have taken the cycles that underwent PGTA but had no euploid embryos for transfer, right? And this is where I just want to stress on these 3 things. These 4 things is what they have talked about. A modified Poisson regression model was used to evaluate the overall association between PGTA and cumulative live birth, adjusting for covariates per retrieval per individual, which are these. And here I'd like to mark ethnicity and race, which I'll talk about in just a bit. And age stratified analysis, of course, they do this that we see in their results table. And finally, they do a sensitivity analysis, which is basically a what if analysis. What if we compared cycles that underwent only frozen embryo transfers, what happens? But there has to be a reason or a basis for this because you're trying to explain the difference that you have, which is why you do a sensitivity analysis. So just a brief word about regression before I show you that next table because it's very confusing. You know that there is something known as confounding. That there are, if I say PGTA is leading to a higher live birth, cumulative live birth over women who haven't had the intervention, then I need to look at if these women are younger, if these women have a shorter duration of infertility, if their BMI is less, if everything else that can affect the outcome independently is well matched within the cohorts, the 2 cohorts or not. This is where, in order to match the other confounders, the other variables that can independently affect the outcome, one does what is known as regression modeling. Okay. Now, there are different kinds of regression models based on the outcome variable you are studying. The one that you would have probably heard of is binary logistic regression model, and that is the one that's most commonly used. So when a word like Poisson comes into, our parlance, you have to ask, why has this been used? What is binary regression model? Binary regression model is used where you have a binary outcome, live birth or no live birth. It's a yes or a no answer. However, Poisson, I'm just going here to this table. and talk about outcome variables, right? So your live birth is not a continuous variable, right? Continuous variable would be something like a fertilization rate, or in this example, pain scale, anything that can occupy a value from 0 to 100 or whatever. Binary or categorical, live birth is binary or categorical. It's a yes or no answer. Oocyte numbers is a continuous variable. Oocyte number can also be counts. Then third kind of variable is a count variable. Count variable is when you have a certain number of events happening within a cohort over a certain period of time. Usually the number of events that we are looking at are fewer. So in this case, right, where you have a count variable and you outcome variable, and you're trying to adjust the influence of other confounders, you use what is known as a Poisson regression, right? For a binary cat or a categorical variable, you use what is known as a logistic regression. Now, let us see why they move to counts instead of binary. That is the results. I'll take you there in just a bit. And these are some of the differences between Poisson and logistic regression. You needn't sort of go into the details of this, but remember that the outcome variable for a Poisson regression is count data. For a binary logistic regression is a binary outcome data. We come straight to the number of observations, the outcome that you are looking at. Each observation can have multiple events per observation. So each cycle could have multiple births. So multiple transfers could lead to multiple births. Here you will have from one cycle, whether the live birth occurred, yes or no, is what you're looking at. So when you have cumulative live births as your outcome, which is all the live births that happened from the embryos that you made in one cycle, it could be 0, it could be 1, it could be 2, and in a rare event, it's also been 3 for some reason. You do what is known as a Poisson regression analysis. So it's not just a yes/no answer. It's also how many live births have resulted from that one retrieval cycle. Okay. So what are covariates or confounders? Now here I have highlighted, these are the ones that they inputted in the variable, right? So age here becomes a huge confounder because it has independently affected the intervention, which is how many cycles of PGTA were done in that group. And of course, age, you know already that it affects the outcome, which is live births, right? The others are there as well, but here race and ethnicity, which they have inputted in their model if you go into their statistical analysis, and I do that a lot, and I encourage you to do that a lot to understand a little bit of a statistics to understand this. You don't need too much. You don't need to go into mathematical modeling, whatever, just understand the words that have been used. And they use race and ethnicity as one of their covariates, which is also fine because many studies use this, and it has been found that blacks versus white, there will be a difference. Asians versus whites, there will be a difference, not in favor of Asians and not in favor of blacks. So however, they also mentioned that a third of this data was missing, and the missing data in any of their text has not been addressed. What does this mean for the regression analysis? That should have been told, but in the absence, I as a reader would want to know if these, because regression, what it will do is even if one of the entries of the covariates is missing, it will eliminate that from the analysis. Did they address this in any way? And a third is a huge number. Or did they input this at all or just remove this entirely, although they mentioned that they have done this? So that is something which is leaving a bit of a gap in understanding their results. Now, these are the results, although you will see that these are the number of embryo. I mean, it's a huge table, but I don't want to walk you through the entire table. But this is one table which presents the results of the number of embryo transfer cycles that women had in these 8 stratified cohorts. So there were no embryo transfers. You can see the first column is without PGTA and the second column is with PGTA. And this is an average of what has happened. I've managed to cut that out completely. But 1 is no PGTA, 2 is with PGTA, and 3rd is the overall cohort, what is happening in the overall cohort. Similarly, no PGTA, PGTA, and overall. No PGTA, PGTA, and the overall cohort. So the first column, as you can see, there have been no embryo transfers, about 3% in this group, in less than 35, 7.7% in 35 to 37, and almost 20%, 1 out of 5 women underwent no embryo transfers in the 38 to 40. And that is a significant figure. Just wrap your head around that, that these many women will not have any embryo transfers, right? For the other group, which is not having any PGT intervention, it remains at 0, 0, 0. Right. So if you want to understand the study, after doing that PICO thing, what is the numerator, denominator, how have they analyzed, what is their population, quickly move to the result table and look at what is happening in the table, right? So once we are looking at what is the number of, the rest is, of course, you can go through that. I'm not going to walk you through every detail, but these are the number of live bonds, 0, 1, 2, and 3. And this adds up all of these in cumulative live births. So the number of events, 3 live births, which are at 3 separate time points, have been taken as 3, resulting from the total number of embryos formed in that cycle. So if we were to now look at adjusted odds ratios, because that is what you're looking at post your regression equation, what is it talking to you about rate ratio or risk ratio, RR? So this is the final thing. Cumulative live birth in the less than 35 is 0.96. It's actually less than what you want it to be. You can see this is the confidence interval, right? This is the point estimate, 0.96. This is the confidence interval, 0.93 to 0.99. And this is the p-value. But before I know you understand p-value, but I want you to understand the significance of the confidence interval, which is that if it crosses unity, which is the line of no difference, it is automatically not significant, right? This one doesn't cross the line of unity. And what it is saying is that it will lead to, the intervention will lead to a reduction in cumulative live births in the age group less than 35. In 35 to 37, it's 1.04, but the confidence interval is 1 to 1.08, which is that it is possible that if you, the results can vary maybe with a different analysis. It's not a very strong association. 38 to 40, 1.07 to 1.2. There is something happening here. Cumulative live births. Remember, they have the denominator as all cycles that underwent PGTA, even if they had no embryos for transfers, right? So now they're not happy with that. They also do a sensitivity analysis, which is analysis of cohorts with no fresh transfers after adjusting for covariates, cumulative live births. So here they are looking at what happens when, because PGTA women, all of them underwent frozen cycle. What happens when non-PGTA women, and we eliminate the ones who underwent fresh transfer, but only taken those who went through freeze-all and subsequent transfer cycles. And they find that there is a difference, right? In favor of PGTA. They are saying it's 11% more likely. Again, this difference is valid in age groups more than 35, but not less than 35. I would have a little bit of an issue trying to swallow that, right? I would want to ask the question, was a sensitivity analysis necessary? Because the standard practice is to not forego the fresh transfer, right? So some of us still undertake fresh transfers in non-PGTA cycles. Let us say that a fresh transfer was undertaken only in the non-PGTA cycles. The question that I'm asking you, Aarti, just I hope you're still there and awake. The only last question that I'm asking you, that if fresh transfers were to be eliminated from the equation, who will it benefit? Will it benefit the PGTA group or will it benefit the non-PGTA group? I'm asking you that question. I'm stopping my slides.
Non-PGTA group, because fresh transfers,
Yeah,
PGTA
fresh,
doesn't happen in fresh transfers.
mildly lower chance of getting pregnant, right?
Very-
Some 10%, whatever, different studies say different things. It definitely does not lead to a higher chance of pregnancy, right? So if you have eliminated the cohort or the group, the subgroup with lower chance of pregnancy through fresh transfers, what should your risk ratio have been? It has gone up in their analysis. In at least in our heads, at least logically speaking, it should have gone down from 1 point, whatever the baseline is. They said 1.07 is the baseline in that cumulative live birth thing I showed you. It has gone up to 1.11. The question you have to ask is why, and do they explain this at all? What was the need for the sensitivity analysis, and why did they do it, and why is the pregnancy rising with after elimination, the results rising for the PGTA group, when it should have actually benefited the other group, right? So I'll end it here, and that's just a thought I want you to try and linger and move on to the next expert who will be asking you questions and discussing the next part of the thing with you. Dr. Mohan Kamath is known to you and known to the entire audience, and we are very lucky and glad to have him with us.
Yeah. Okay.
And
My slides are there. No, no worries. I'll get on.
yeah, go
So
ahead.
I thought my thought process will be okay if I have the slides. So Aarti, I want to know that after reading all this, are you going to offer PGTA to your patients?
Sir, again, it depends on the age. I am not going to offer.
39.
Sir, 39 to 40 could, but it also depends on the number of blastocysts that they have. So
नहीं,
because
आप
there
अगर
is,
अगर no, I'm just giving you a real life scenario. The patient couple has come to you, and that's what we are looking at, isn't it? After the study, we are just trying to see whether we are better informed than
hmm,
where we were. So you've done a study, you read through it, and uh, now you understood the study, and I think the great detail, everything has been done. So how confident are you that it's time to think of offering in this group? That's what the study is suggesting,
it is
isn't it?
suggested that the study suggests that it should be done at more than 38 years. But sir, we also have to look at the number of embryos the patient has. PGTA cannot
So
be.
that brings, yeah, that's a good point. So that brings me to the question, when do we decide about PGTA? On the day of blastocyst, or before the transfer, or before the cycle starts? When do we actually discuss all this with the couple?
So before the,
That's what, as a clinician, when will I do it? I don't know about those who are offering, but I would suggest that we will
should
be
be
actually
before the
offering this way when we are actually planning the IVF. No, we are not going to tell them,
policy.
listen, you need to have 1 lakh extra or 2 lakh extra because I'm going to do a PGTA. This is very much a part of our clinical counseling at the time. So that's where it is. Okay. So that's fine. So I'm just kind of come to couple of points. This is just three slides. Okay. You just have to hang around for 3 slides. What we are trying to do here is we have gone through the paper, we dissected it, and now we need to come to a big question whether we want to actually offer PGT after this great study, which has come up with some 50,000 cycles. It's published in one of the top journals, American. So we tend to go by whatever is published in fertility sterility. So I just want to see if, before I go to that question, I must add here for our audience that whenever you're looking, this is not any regular cohort study. It's not a single center study. It's a database based study. Okay. And data sets across UK and SART. Please remember one thing. There is something called cyclicity issue. So if you are carefully looked at it, they kept saying per cycle. They have not said per woman. So there is a good chance that a lot of women have repeated cycles in this data set. Okay, so that is considered a limitation of the database because it can happen that poor prognosis cases keep coming back. Yeah, just this is a statistical point. I thought I have worked with the UK HFEA database, so repeatedly the peer reviewers caught me here, and that's why one of the ways we actually worked around this was we said, okay, cyclicity is there, we will not go by the traditional 95% confidence interval. We'll go to something called 99% confidence interval. So that is to make it more robust and valid. That's besides the issue, but just observe that all along in the article, they have used cycles and not women. Yeah, so that's one of the limitations, because it's not a cycle linked data. So there is a concept called cycle linked data where the investigators are provided a cycle link, but here I don't think that has been done. It's cycle, it's not per woman. So coming to my answer to how to go about this. So it is very important for us, before we start reading this article, where are we right now in our own mind? So I don't know about others, but this is what my thoughts are on PGTA right now. My current thinking is there an equipoise? I am heavily influenced by the current landmark trial, which is published in NEJM on PGTA, which all of us are aware, which clearly showed the cumulative live birth was lower following PGTA in good prognosis cases who had undergone at least 3 embryo blastocyst transfers. Okay, that's where the current landmark trial or the best evidence for the PGTA stands. And this was just a couple of years back. And it was a big trial, 1,200 or 1,400, I can't remember. This is why my thinking was heavily influenced by this, but it also vindicated a lot of my own thinking on this topic. So let's look at the biological plausibility. So I'm happy to have a discussion, but my clear thinking on this is that cumulative live birth will never increase following PGTA. That is, if we use the right definition. It will either remain same or it will decrease following PGTA. But it can increase per embryo live birth rate. This is where my thinking is as far as the biological plausibility is concerned. I'm happy to discuss this with anybody. But remember that we have a pool of embryos. PGTA is a selection method. If I end up transferring all the embryos, eventually the live birth has to be same as any other arm, even if I don't offer PGTA. It remains to be seen whether the patients will last that long. Yeah. So one of the biggest problems with this study, and that's what shakes up my confidence in the study, is there is a huge selection bias. And that is something that we have to be very quick and be on that Hawkeye mode that I call it, to pick up from the study. So very cleverly, there's a control has been put on a disadvantage. And there are clear reasons. You can actually, the authors have listed it out, but we can clearly see this. They have arbitrarily decided that only greater than 5 fertilized oocyte patients will be in. That essentially means 39-year-old, most of the times I get 4 or 5 fertilized oocytes with great difficulty. I don't know about others. I'm happy to share our experience, but Gangaram or any other center, how many of us will get more than 5 fertilized oocytes very often at 39, 40? Very rare. So they have actually taken off a big chunk of patients whom you are actually going to offer PGTA. Then they restrict it to only 3 blastocyst transfer, up to 3, very cleverly. Now, if you really go by cumulative live birth definition, it is either the couple has a baby or they exhaust all the embryos. Now, that is typically against the non-PGTA cycle, because non-PGTA cycle will lead to more embryo transfers. That is given. There is no brainer. Okay, so they have given a disadvantage is position to the non-PGTA, because I might take 4 embryo transfers to reach the birth in a non-PGTA cycle, whereas in PGTA you might reach at 2. And the third is, of course, freeze-all cycle. Now they have, I think Ruma pointed out, and this point is very well taken. PGTA, a freeze-all cycle, the PGTA will do better because fresh has been taken out in the non-PGTA, because you'll put the best embryo in the fresh. So whoever is remaining is going to be not so good embryos in the non-PGTA arm. And finally, of course, the standard of care is much more flexible. You know, you might have a double embryo transfer at 39-year-old lady. It's not excluded recurrent losses, recurrent implantation failures. So the standard of care is quite flexible. Standard of care can be a day 3 fresh transfer, day 3 double embryo transfer, a day 5 fresh, day 5 blastocyst, anything. It can't be straitjacketed into a single blastocyst transfer. It puts the control under a disadvantage. So this is the picture I show every time. Here it's clear that the PGTA arm has been given a big advantage, and it's not like they are on the 100-meter race. No, it's been given the start of a 400-meter race. That's the way I picture it when I look at it. So finally, the question, if you ask me, will I offer, because that's what the study is suggesting, will I offer PGTA to a 38-year-old plus woman? I will ask myself, how many of the patients will reach blastocyst which needs a biopsy? Very few in my setting, I would say. And this is most likely because they are Poseidon 3 and 4. Most of them are Poseidon 4, the way I understand. And how many will end up with no ET? And this is the data that Ruma did point out. The 20% patients did not end up with an embryo transfer in the PGTA group in this group. So we have to face every fifth couple that I counsel with a no embryo, which is quite a big issue. If you really are in private practice, you can't, really counsel this. And a lot of them will land up with those unequal reports, which are like mosaic, and we don't know, no reports, and so on and so forth. So there's a huge problem once you go on this path. So to me, I think the answer is clear. Only something really big and another landmark study is going to shake up. Otherwise, this study is good to critique. We can have a journal club, we can critique it and learn, but it really doesn't change the clinical equipoise in my mind. And I've given the reasons, and I'm happy to discuss that if at all there's a need to do that. But I close my case here. Yeah.
Yeah, many thanks, Dr. Kamath. But you correctly point out that you have to understand the biological plausibility of how events and phenomenon happen. And you say that if at all, I mean, if absolutely, fully, and correctly done, it may just keep it stable, your live births, cumulative live births, or may bring it down if one doesn't have the expertise for doing this. But it can't improve it. I mean,
It will actually bring down. See, we have to be very careful. The trial, of course, brought down the cumulative live birth, and which is what we were looking at, 5% live birth. But also in this particular study, there is a clue there. Why did the live birth go down in the less than 35 years age? How do we explain that? The damage is being done, and that's where it is hidden. It's just that we don't want to look at it. That's a different thing. Yeah.
Right. Yeah.
Thank you all the delegates for the first. Thank you to all the experts for the first paper. It was really nice. Dr. Mohan Kamath, you actually asked the question in the group and you explained it yourself very nicely. Thank you so much, sir. So for the next paper, it's a very good, interesting systematic review and a meta-analysis published in 2023 in Human Reproduction. How common is a natural conception in women who have actually had a live birth after an ART procedure? So for that, I would like to invite for the paper presentation, Dr. Richa Advani. She is an IFS fellow at Sir Gangaram Hospital with us. So Richa, all over to you. Please unmute yourself.
Good evening, all the seniors and all the delegates. So can I share my PPT, ma'am?
Sure, you can do this.
Is it visible, ma'am?
Yes, we can see it.
So, ma'am, I'll be presenting a meta-analysis and a systemic review in which the question was, how common is a natural conception in women who have had a live birth via assisted reproductive technology? So this was published in Human Reproduction and in June 2023, and this journal had an impact factor of 6.1. So as we know, the annual births are about 1 to 6% through ART. Post-ART as well, certain women, they conceive naturally. So this has been described as miracle pregnancies, and these have become of importance and interest. And that is why the systemic analysis and systemic review and meta-analysis was undertaken to synthesize the incidence of natural conception pregnancy after ART, that has appeared in various studies. A possible explanation which has been explained for this is that ovarian stimulation from the IVF cycle improves the ovarian functions in a similar mechanism to that of a surgical technique which we do in ovarian drilling, as well as other hypothesis could be that the pregnancy itself leads to conditions like endometriosis regression, as well as a stress reduction after the conception could be a contributory factor for the conception in the next pregnancy. The research questions which was put, the population was the women who had a natural conception, and it was after AART, and the outcome which was measured was a conception or a live birth. Coming to the study search details, so this was a systemic and a review with meta-analysis as we know. The database which was used was Ovid Medline, Embrace, PsycInfo, Cochrane Library, HFAA and HRA websites. These were searched from a duration of January 1980 to September 2021 in English language for human studies. And the inclusion criteria which they had taken was the studies with the outcome measure of proportion of women experiencing the natural conception after the ART, live birth. And the studies which did not have these desired outcomes were excluded. Coming to the study appraisal, so critical appraisal skills program cohort study checklist was used for the cohort studies, and the access appraisal tool was used for the cross-sectional studies. To determine the representativeness of the sample, the validity of the data collected, significance and generalizability as well as applicability of these findings. The outcomes that they had measured and the subgroup analysis, the random effect meta-analysis was adopted to get a pooled effective estimate of the proportion of the natural conception pregnancies after the ART live birth. And the subgroup analysis which was done for the outcome measures, the type of the ART, and the length of the follow-up. Coming to the PRISMA flow chart of the systemic review. So as we can see, the records were searched in the databases which we have already discussed, and then the studies were screened and eligibility criteria was put on them. After exclusion, finally we got 11 studies which were included in the review. Out of these, in these studies had 5,180 women, and there were 7 retrospective studies, 3 prospective studies, and a single cross-sectional online survey which was included. And after including these studies, for the risk of bias, they had selected, done different domain was checked in all these 7 studies. The risk of bias was specifically assessed, and as we can see, a traffic light plot of the domain level judgment was made. And majority potential bias was seen related to the domains of confounding, selection bias, and missing data, as we can see in this picture. Coming to the forest plot of the studies for the proportion of spontaneous pregnancies after live birth via ART, as we can see at the forest plot, the diamond, it is at 20%, which is the pooled estimate of all the studies. And apart from this, the subgroup analysis was also done. So there were 4 studies which had taken into consideration even the live births. So the pooled estimate of this was 18%. Coming to the second subgroup analysis, which was considering the type of ART which was used. So IVF was used in 2 studies, which brought a pooled estimate of 13%. IVF plus ICSI was seen in 8 studies, which had a pooled estimate of 21%. And ICSI was there only in 1 study, and it had a pooled estimate of 20%. Coming to the third subgroup analysis, which was about the effect of length of follow-up. So less than 2 years, it was 33%. And at 2 years, and it was 16%. At 3 years, it was 18%. 5 to 10 years was 20%. And about 10 to 15 years, it was 14%. Coming to the different factors which had affected these results, it was a younger age group, a shorter duration of subfertility, fewer treatment cycles prior to the first delivery, and a specific cause of subfertility could also be affecting the occurrence of these spontaneous pregnancies. So this shows the association of these specific causes. There was a positive association of unexplained infertility, subfertility, and endometriosis, and there was a negative association of tubal factor and male factor. That is, if these were the causes, it could have affected the occurrence of the natural conception. Coming to the conclusion, so this natural conception after ART was previously thought to be a rare thing, but in their systemic review and meta-analysis, it has come as 1 in 5 women could have the natural conception, and it may occur in 18% of the women in the first 3 years after having a baby via an ART. The limitations of these studies were that they had wide variation across the methodology, the population, the cause of the subfertility, the type and the outcome of fertility treatment, also the length of follow-up, thereby leading to the potential biases which we had seen of confounding selection bias as well as that of the missing data. Thank you.
Thank you, Dr. Richard. It was actually a very good presentation, and you really made a good presentation out of the paper. But to have a discussion on the research question and the study design, I would like to invite Dr. Shalini. She is the clinical head and at the ART Center at PGIMER Institute in Chandigarh.
Uh, Thank you for having me here. So, my question to Richa is, do you think it was a nice question? It was a good question, research question which had been framed. And would you like to tell me something about the research question which was on the basis of which this meta analysis was carried out?
Ma'am, they wanted to know how common is the natural conception after live birth. So they have described the intervention, that is the previous ART. They've also discussed the outcome in the research question, and they have also mentioned what they were expecting. That is their main aim of incidence, or how much is the natural conception rate they wanted to know. So I think
So,
they had
at
justified.
the outset of the design, when you are making a research question, your research question, I mean, in if I look at this study, as Dr. Ruma said, we should, with a pinch of salt, take the studies taken even from very big platforms like Fertile Sterile and Human Reproduction, where this paper, I mean, was published. So if you look at this study, there is a question which was put, and it was a good question because it gives us the answer if any patient comes to us asking, what is my chance of having a natural conception after I have undergone an ART? So you can say, okay, I have, with this 0.2 proportion they have given, with a confidence interval of 95%. But if you look at the quality of the studies which were included in the meta-analysis, what was the quality as per your reading this paper?
Ma'am, they were of moderate quality, most of them.
So how was the moderate quality assessed?
Ma'am, as per they had there were cohort studies included, as well as there was a cross-sectional study which was included. So for
Yes,
cohort
you
study,
look at the range of the studies, they were in 22 years. They almost started searching from 1980 to 2000, I mean 2021, when they did the meta-analysis. So till 2019. So almost all the studies, and they did the study, the good part of the study is that they have done it very beautifully. I mean, because of which this paper has come in Human Reproduction. The quality of data analysis and the I mean selection has been very good. But if you look at the research question, the quality of studies which were included and selected into the study, there is a heterogeneity of data, the indications, if I would go on it now, there were, most of the studies were retrospective. So if you need to actually answer your research question, you need to have similarity or uniformity in the indication for performing an ART. So here there are some studies, like if you look at the study which is done, the second numbered study, they have used unexplained infertility, unexplained subfertility, and they've also taken the patients with mild male factor. So if you include, and if you go by the nice guidelines, IVF can be offered to most causes of subfertility, including those of potentially lesser severity and duration. So the indications have changed, and that is why the studies which are more recent have a more natural conception compared to the previous older studies, because now we are loosely giving IVF because of many other reasons. And in the nice, they have, in this particular study, they have not excluded, when they were the same partner, conceptions were there. They have also talked about single women where donor sperms were used, and they have also included surrogates. So I mean, I don't know, these things have not at all discussed in the study, in the individual, and they have no individual studies, they have not even talked about that. The good part of the study is that they have, I mean, the screening part and the indications for which they have taken. Of course, there are not, you do not expect too many studies have been done on this particular topic. But if the studies, I mean, if we, to have a better answer in future, we should have, probably indication wise. Suppose we take severe male factor, and we do, what are the chances of having, after they have undergone IVF ICSI, what is the chances of their having natural conception. Then individualizing, as you said, that there is a negative correlation with the male factor and tubal factor. So here they have also included anovulatory women. In one study it is 10%, in the other study it is 18%. Women where IVF was done, I mean, 18% of the women formed the part of the study, who were anovulatory. So we all know that anovulation can result in ovulation, and they are undergoing IVF. So I mean, these are my few queries. So can you just tell me about, what was the contribution of these authors? You went through the study, so how they did, I mean, just discuss the methodology a little more for me.
Ma'am, they made a set, they described the population which they wanted to see and the outcome they described, and then they went to the database and all the literature search they did using certain keywords that which was included, like live births, natural conception, ART, and the results that they got, then they screened them whether they had the outcome which they were looking for. And then the ones which had that outcome, they included them in their study, and then they searched whether there is the bias which was there in this study, whether it was more or less according to the tools. They used the tools, and then they assessed the risk of bias in these studies, and then made the pooled analysis uh, after that, so as to come to a conclusion.
So the risk of bias assessment was done using traffic light plot. So you have any comments on that? What was the, what was the final assessment of this traffic light plot?
Ma'am, as we can see, there were the main, in the traffic light plot, they had used 7 domains for all the studies. They applied the 7 domains, and in the traffic light plot, they had given the colors coding: low, some concerns, high, and very high concern for the final judgment in those study for that particular domain. So it gives a pictorial view after looking at the graph in one point, that we can see in the domain 1, domain 3, and domain 5, which was bias due to confounding, bias due to selection of participants, and also bias due to missing data. In
So
these were the domains in which these studies were having problems.
makes the study a very, not a very good study.
Uh,
So if there is a, I mean, there is a heterogeneity in the selection bias, then there is, of course, there is missing data. Then there are some studies where the questionnaire was answered by postal, and the questionnaire was telephonically answered. So and there was a lot of missing data was there. So of course the results were globally, I mean, there was less bias assessment in the result assessment, because of course they were assessing the pregnancies and all. So I mean, these are my few comments. And if you look at the this 2013 study by Ventner, There is no difference in women who had first spontaneous conception. I mean, what have they compared? They have taken the women, they've done ART, they had one spontaneous conception. Then they have taken the women, who underwent ART for some reason, and then they compared for spontaneous. Of course, you were not expecting, you were expecting spontaneous conception. So such kind of studies, if they are included in the meta-analysis, they will change the whole meta-analysis results, and we cannot apply these meta-analysis results to our population or in our counseling. So I mean, my take on this is that the research question, probably we should have better kind of studies. We should have prospective studies with indications very well defined when we are including the studies, rather than taking generalized studies with where the indications are not well defined. Do you agree with me?
Yes, ma'am.
Yes. So that's all my I had to say about it.
Thank you, ma'am. It was a very interesting and a very critical analysis of the research question. A very good eye opener for all of us. And to discuss the key statistical concepts of the paper, I would like to invite Dr. Mohan Kamath again.
Yeah, I just want to share the slides, please. Can somebody?
Richa, can you just stop sharing your
Yes,
slide?
ma'am.
Yeah, so okay, let me just see what I'm trying to do. Okay, so basically it's I think why the HR has published this is because it's a very important clinical question for our patients. That's why. Otherwise, human reproduction does not publish systematic reviews. Systematic reviews generally are published by Human Reproduction Update, which only publishes systematic reviews. So you won't find systematic reviews very often in HR. So the editors, and generally, if you ask me, I would be very happy with this kind of manuscript being submitted because it is so relevant to our patients. Only studies which are very relevant to our patients normally make the score in many of these journals because that's what we are here for. Now, I'm not going to go too much in detail because systematic review statistics is a big class in itself. So I'm just going to touch what things were done in this review and what we should probably know in the next 2 minutes. They have done a good thing. They have actually registered prospectively, and I'm not sure if Richa spotted that. Do you think you found that where it was registered, where was the number? So if you look closely in the abstract, at the last of the abstract, there is something called registration, and there you can see that. So typically, just like randomized trials, which we register prospectively, and we have a protocol in the public domain, similarly, for systematic reviews, we should have a protocol registered, and it's usually non-Cochrane reviews are registered with Prospero, which is University of York. Okay, so anybody can register and they can lay down how they are planning to do the systematic review because systematic reviews are normally a retrospective work. Like it's looking at retrospective work. It's not never prospective. So it's going to look into only older studies. It's not in future. Okay. The other good thing they have done is they have used at least good 2 or 3 databases and they've covered most of the databases, though there is limitation. So for people who are beginners, uh, if you look at it, they have restricted to English. Whereas there is, you know about Lilac, there's a database which is in Spanish. And Spanish is one of the most spoken languages in the world. Apart from our neighbors, Chinese databases also are missing. So that's where the limitation starts. So they are likely to miss studies which were published in Spanish and Chinese and many others. Then I found the statistical detailing was very minimal in the method section. And this is possibly, again, as I said, why? Because human reproduction does not publish systematic reviews. So systematic reviews run, actually a Cochrane review runs into 80 pages. So that kind of word limits are not there for a human reproduction article. So probably they were very economical in the details because as a reviewer myself, I would really focus on how they went about doing this. Probably they have it on the Prospero registration. So I would be keen to see what were the studies they wanted to do, include, and what were the designs and how they were planning to investigate something called heterogeneity. And I would expect a lot of heterogeneity in this study, in this review, uh, because I'll tell you the reasons. But I just want to make it clear. People often confuse meta-analysis and systematic reviews and so on. I see that word very often being interchanged. They cannot be interchanged. They have their own meaning. All systematic reviews are basically a systematic work into evidence collation. We collate the evidence. Meta-analysis is when in the systematic reviews, if you find at least two trials or two studies which can be pooled together into one, that's when the meta-analysis comes. So never describe any study as a meta-analysis. That's a very big, a lot of people make that mistake. It's always a systematic review and a meta-analysis. Okay. But uh, it's never, even sometimes titles are given as a meta-analysis. Meta-analysis is a sub part of things. You can have a systematic review without a meta-analysis, but vice versa is not possible. So that's a confusion I wanted to clear off because a lot of people are not clear on this concept. Finally, couple of slides. Do you expect the studies to be similar, Richa?
No, sir, because it was not done primarily for this purpose. The studies were done for other causes, and later on they decided to look this outcome in these studies. So the cause, the population size, the factors for which fertility treatment the patient had undergone,
Yeah,
there was a lot of
rightly.
heterogeneity.
Yeah. So essentially, it would differ. Like if you are doing in Gangaram, your IVF population might be different from what we do in CMC and PGI and so on and so forth. It depends upon what kind of patients are coming to us, and they would differ center to center. Okay, and then there is one more important angle. It's the follow-up period. I might decide that I can track only for 10 years. Somebody can do it for 15 years. Somebody can do for 3 years or 4 years and so on. And there'll be a lot of attrition. So if you are planning this study in India, do you think you'll have problems capturing at a 5-year follow-up?
Yes, sir.
Yes. But if you do it in UK, you will not, because you just have to put the NHS number and you will track them down. Yeah. So
Yes,
that's
sir.
why our studies will be not as robust, and there'll be a lot of attrition. And that's what happens in these studies. Why do you think the natural conceptions were found to be more in the recent studies?
So because of now, because we have developed more technology in ARTs, so even subfertility patients are offered ART at an earlier stage compared to previous years when ART was very new. So it was offered only in extreme conditions or at a later
Yeah,
stage.
that's a very good way of looking at. I'm a little more less forgiving. I feel that a lot of patients are offered even when they would have conceived naturally. That's what Dr. Shalini was trying to tell. Nowadays somebody is unexplained 1 year, 2 year, we can just put them on the fast forward mode and take them to IVF, and they have their first baby, and the second baby comes anyways after a couple of years. So that's what is the probable reason why natural conceptions are looking more in the recent studies. So that was an interesting finding. The final one is this. This is the forest plot, and this is what I think the main learning is. So can you tell me how did they find the 20%?
So
That's the
they
data they have
pulled,
quoted.
because there was heterogeneity, they used the random meta-analysis to come to a conclusion
Yeah,
of
that's
all
fine.
the
I just
studies.
want to know which part of this whole forest plot is telling you that. You
Last
can
diamond
see here
part, sir.
down.
Diamond.
Yeah, next to that. So is that the what do you is there the truth, or how far is it's lower and the upper limit?
Sir, because this is actually a study in which we are seeing the prevalence or incidence.
No, that's
So,
fine. What do you think? 20% is the point estimate. So where do you think it can go down or up in terms of your estimate? It's not a fixed number. So that
down,
confidence interval I have marked out
it
here.
is
I'm not sure if you can see the cursor here. Okay. I'm not
down only it
yeah,
has
down
shown.
one. Yeah. So
Yes,
you
sir.
can see the confidence interval
0.1.
lying between 0.17 to 0.22. This essentially means 95% time the truth is lying between 17% to 22%.
22.
Okay, so we might have a chance of natural conception between 17 to 22. But when we talk to the patient, you still are perfectly fine saying 1 in 5. Whether it's 17% or 22%, you're really not going to get into mathematics with the patient. You are just going to make it 1 in 5. Okay. The second
Yes,
thing
sir.
I would probably point out here, so that's how we read the confidence interval and the point estimate. This is where it is. She basically the whole study is on this fun figure. That's what they did, all the hard work to get this number. Second is if you see on the left side, the heterogeneity, that's the I square 82%, which essentially means a very high heterogeneity. even without these numbers, do you think you could have spotted that the heterogeneity is very high? So the way to read this is, if you look at the confidence intervals in these plots, if they are not overlapping broadly, that means the studies are heterogeneous. So you don't even need to read the I square down below. If you see this one, can you see the first one? And can you see this winter or whatever? It's
Yes, sir.
way, one is saying this way, the other one is going that way. That means there is a lot of heterogeneity. Okay. And finally, can you spot the study which is the largest study?
The one winter and landed, their line is bigger, so that is the
No,
largest.
that's the opposite. Sorry, but I just have to tell this, that the line, if the confidence interval is the largest, it's the smallest study. Okay. And the confidence interval is narrow, means the study is big enough.
Bigger.
And if you think I am not telling the right way, all you need to do is look at the numbers here. And which is the
Yes.
largest one? 1,300.
1,300. Yes, sir.
Okay.
Yes, sir.
So that's why this is how you read the forest plot. The moment you see the confidence interval, you know this is the largest study. I don't even need to look at the numbers. Yeah.
Yes, sir.
Any doubt? I think I'm done here. These were the concepts I really want them to probably know in a systematic review. And I think generally, to me, if I take home a message from this, all I need to know is that what am my patient interested in? My patient is interested in what are my chances. I've had a baby with IVF, and what are my chances? So I can say it may be between around 1 in 5. I'm not sure about the numbers, but you still have a good chance. And 20% is a good chance, considering that IVF itself is around 30% live birth. The second, but the information that is missing and that is worth looking at, it is, does this live birth numbers change according to the indication for which the IVF was done? So I would be keen to see anovulation and unexplained. How did they do? That's where I would be interested in. Yeah.
Yes, sir.
I think that question is also answered here in this particular study, because when they say negatively associated indications were tubal factor and severe male factor,
Yeah.
that is what you said.
Yeah.
So
Yeah.
that question is also answered. So we do get some answers.
Some
The study
answers.
is
Yeah.
done beautifully. Probably a better answer could be possible if the indications would have been. I mean, that's a very difficult thing to do,
Yeah.
and
It is difficult.
probably this data can be, I mean, thought of looking at this meta-analysis for the future studies. You can keep on segregating your data, and data extraction can be done in
Yeah.
taking specific indications.
Yes.
Absolutely. Thank you, sir. Thank you explaining the statistical part and especially the forest plot again and again. We always learn, we keep on forgetting it. Thank you so much.
I'm there for some time. I can keep on explaining this all my life. Okay.
Thank you. So, for the next, to discuss on the result, I mean, how critically we should evaluate the result, I would like to invite Dr. Siddharth Nagareddy. He's a consultant at SNH Fertility and Endoscopy Center, Nellore.
Yeah, good evening, one and all. So very good study selected, and I should thank Dr. Ruma ma'am and my team as well for all that, and for having given me an opportunity to participate in this. So basically, when I look at the methodology, the methodology seems appropriate to me. So if I could ask the candidate, how was there any problems with the methodology and selection system, and the quality checks done for the studies? So they were clearly explained. Do you agree with me? Like
Yes,
Dr.
sir.
Shalini, I believe. So I think that aspect, but the problem here is, so there's a lot of heterogeneity with these studies. So that's probably so when there's a lot of heterogeneity with these studies. So whatever the pooled estimates of the cause of infertility, which has shown significance. So whatever it is, when there's a lot of heterogeneity, it's very difficult. When a patient. So when you put these results into clinical practice, I think that's what I'm asked to speak. So how to take the what is the face value of those results? So probably we can assure patients that probably there is a chance of natural science conception just to give them information about it. But we cannot say that probably when you have an IVF failure, you probably should try conceiving naturally and 18 to 17 to 22% of the time or 18% of the time. So what do you think? So with this data and with this heterogeneity and with this risk of bias being high and very high in majority of these studies selected for this review, do you think, and there's no, I mean, there are a lot of things which have been excluded, like the cause of infertility for which the cause of infertility and the contraception used by the couple and the duration of infertility for which the IVF was done and for which the IVF have been offered in different regions. So all these will have effect on the studies done in those regions. So do you agree with me?
Yes, sir.
So now, are we in a position to extrapolate these results to clinical practice, saying that because 18% is a very good number? Because normally, if I, as a clinician, I would say, if I'm able to catch you, promise a patient, I tell a patient that 12% is an IUA pregnancy, then 18% of spontaneous pregnancy is very high. Then I have IUA pregnancy per cycle in my clinic at least. So, but sadly, probably in my opinion, though this is a very good, very valid information, and this opens up a lot of scope for. That's why human reproduction, obviously, why Dr. Mohan Kamas has told, he himself being, involved in human HR update, so being an associate editor of that. So he himself told that human reproduction is published this, which is actually not the business of that because it doesn't do systematic reviews much. So that is I mean, this is a very relevant topic. At the same time, there's a lot of missing gaps in the evidence. Probably some futuristic studies should bring in, should be a more methodically robustly planned to address specific research questions in them. Suppose, like if I want to know what is the chance of an explained infertility couple conceiving naturally, and if a study has been very well planned, very well designed, so probably, whether I'm not sure whether such a study would really be possible, but to the nearest possible level, if that could be done, and specific questions answering for the studies, that would be really great. But at this point of time, my question to you is: are we in a position to offer this information to our patients and recommend considering them naturally following a failed IVF? Is my question. What is your opinion on that? Because a lot of discussions were done, and because this is what every patient asks. So one patient asks me like whether I can do a tubal recanalization following a failed IVF, because even I have and I'm young and I opted for an IVF, but now I have there's a so lot. It's an endless situation for clinicians like you and me. So suppose, so how do you like which patients, which group of patients based on this study probably you would say you would encourage them rather to conceive naturally if they open up an option with you. Suppose, doctor, can I try naturally at this point of time? So which group of patients based on this study you would think as a clinician?
In which the indication of IVF was unexplained and other factors were not very bad. Like that is her age is she's younger, duration of infertility, that is time to conception was less. In those patients we can consider, but we need to tell them that it might not be that effective. If she wants, we can wait for a little bit of time. If we are not like that is her AMH is not very low, her age is not too much, so we can give her benefit of doubt that maybe this time she might conceive, but we can't tell her for definite that, okay, you might try for certain months and months together. We would tell her that you have to understand that it might not happen also. This is just a chance that we are taking.
Right. So probably that should be more justified, and I would look forward to the comments from Dr. Uma Madam as well. So maybe unexplained infertility in a young patient and wherein you didn't have any abnormal features in an IVF cycle like immature oocytes being more, or poor fertilization or poor cleavage or blastulation. So none of the abnormal features being seen in unexplained infertility IVF cycle. Probably those group of patients, they otherwise have very good endometrium, very good embryos, but sadly not conceiving in 2 or 3 embryo transfer attempts. Probably those are the patients. Probably if they ask whether we can wait, try naturally, or do something, lifestyle changes, or do something else, and do so maybe. But there's no evidence. So I don't recommend to my patients. Probably if they open up an option, probably I would I would give an information about this to them. Because this is a systematic review and meta-analysis. We can just throw it away also, because we need to, and that has been considered for publication in human reproduction, which is very, so we can just throw it away probably. As clinicians, we understand that better, but this is some information at the end of the day, we can give it to patients, I mean, who deserve that.
Thank you,
Yeah.
Dr. Siddharth. I just have 2 comments to make and nothing more. The first is that systematic reviews can be done for many kinds of question, not just for questions of intervention. This is an example of a systematic review where it is specifically seeking the incidence or a prevalence question. It's seeking the incidence of natural conceptions post IVF, right? And the second comment so that is one. And similarly, you could have questions of anything, which diagnostic test is better? You could pool together several studies, statistics from several studies to arrive upon a pooled point estimate. And it is possible to club it into a meta-analysis, provided you have details of how that test is performing. So systematic reviews can be used for prevalence studies to answer questions of prevalence. They can be used to answer question of diagnosis. They can be used to answer question, and we know this for a fact that they are being used to answer questions of intervention. The second comment that I have to make is, can the study design be bettered? How else do you do it? For a question of prevalence, you will have cross-sectional studies, you will have to have cohort studies. And when I look at, of course, there will be heterogeneity unless the reporting standard has been established, like it has for, let's say, SART, for the Nordic registry, or for HFEA. Maybe those are databases that you can look at to see, and something known as data linkage. So you basically link 2 registries, one from IVF and one from subsequent births, and see if the same woman figures on the natural conception list again. That's one. Unless you maintain that kind of data, how else do you do this? You will have to club studies or pool studies that have reported this from different parts of the world. I can see Japan, Germany, Australia, and Israel and other countries on the list. And their methods are described. It's not like they are, each one of these studies, if you look at them, their methods are described. They are looking to seek answers within a certain set of women. They serve them survey questions, or through different kind of, various ways that these are internet based, and they get answers. So, I mean, I agree that the methods could have been better, except that where is that data? So this study is, or this systematic review is clubbing data that exists in order to answer relevant question, just with a greater confidence. Instead of sort of using just one study, it's clubbing 11 studies together. And like you said, logically speaking, which are the ones you expect to conceive naturally? Yes, unexplained. Those perhaps with, have had their HSGs and they report bilateral corneal block, and you understand, and if you've attended some of the talks on HSG, you'll understand that 1/3 to 1/2, and Dr. Mohan here has a paper on this, of how HSGs can report false positive blocks, and that's nearly about 33 to 40%. So even though, I mean, one shouldn't be surprised by this, that, women who had tubal blocks, corneal blocks conceived subsequently. I think we need to relook at who are the women we are offering these IVFs to. And time bound and everything, yes, I agree with you, Richa. But I think for the moment, let's just contend with what we have. This is what we have, right? Yeah, I think I'll end there. Anyone has a comment, please come in.
Anybody has a question also, they can put it in the chat box. And Dr. Siddharth, any comments?
Yeah, no further comments. It has been extensively discussed already. I think we need to take back these messages and probably especially those in fellows, they can take up some research or project regarding this. Yeah, I think everything is very, very well discussed.
All right.
All right. Yeah. Sakshi, you want to end this?
Yeah, sure, I'll end it. So, Dr. Rama, first of all, wonderfully selected studies. It was really good listening to the papers and then the discussion and critically evaluate. I'm sure I learned a lot of things. I'm sure all the delegates must have learned good points about analysis and not taking the results at the face value. So, thank you to all of you, and thank you to all the experts and the presenters. And hopefully, all of you have a good weekend. Thank you so much.
Thank you.
Thank you, ma'am. Thank you,
Thank
sir.
you so much.
Shalini, thank you for being there. I couldn't see you before, but yeah, thank you for being there. I know you were traveling and you just arrived last night.
Yes.
Thank you, Dr. Mohan. Thank you, Garima. And thank you, Richa.
Thank you, ma'am.
Aarti, if you're there, thanks to you as well.
Okay, bye.
Yeah,
Thank you, ma'am.
Bye-bye.